Hello, I'm Omar Castaneda. I'm one of the transplanters and cellular therapies physicians at Moffic. I work with Dr. Hansen and Dr. Grajales. And I'm going to talk to you about what is new, what is CAR-T, how this happened, what could potentially be the journey for the patients, okay? So these are my disclosures. So this is what we're going to talk, kind of an outline of what we're going to talk, how CAR works, some data on myeloma CAR-T, when CAR-T cell therapy is right for you as a patient, the future, and some conclusions. Okay, so CAR-T cell therapy is the name given to what is called the chimeric antigen receptor. That's the CAR, right? Which are genetically modified T cells, right? That are designed to recognize specific antigens, like the proteins on the surface of the cancer cells, right? For example, we've been talking this morning about like proteins like BCMA, GPRC5D. Those are proteins that are in the surface of the myeloma cells. So these CARs are genetically modified to recognize them, right? And by doing so, they can kill those tumor cells, right? They are considered living drugs. In theory, they could be living in your body for many months, right? And depending what product it is, we can have a sort of like an idea how long they may stay in your system, right? And they are generally created from their own patient cells. However, there are newer CAR-Ts that are coming that are being created from donor T cells, right? Like healthy donors will take those T cells from them, and then they manufacture the CAR-Ts using those T cells, right? So those are not commercially available, but those are on trials still at this time. So this is kind of how it happens, right? First, we have a patient. We collect the cells from the patients. These cells are sent to a manufacturing facility, right, a laboratory, where the CAR, right, the chimeric antigen receptor, is added, right, to the cells. These cells are expanded, and then they are back and then sent back to the patients, and they are infused back to the patients, right? That's how kind of like a shortcut of the summary of how these cells happen, right? So this is what a CAR looks like. This is a cartoon of the CAR-T cell, right? It has what we call the antigen recognition domain, right? That's the part of the CAR-T that is going to recognize, that is going to attach to the, let's say, BCMA, GPRC5D, CS1, or the other targets that are available, right? And then recognize this antigen on the cancer cell. And then we have this other portion here, which is the co-stimulatory domain. This will increase the T cell activation, right? It made the T cells more active to enhance the killing function of those T cells, right? And then we have this other like stimulatory domain, the CD3 zeta change signaling domain, which also induces T cell activations, right? This is what we call here like a second generation CAR-T, right? And the both myeloma CARs that are available are kind of the same sort of like structure. So this is kind of like a generation walk through what we have available either commercially or in research for CAR-T cell, right? We had the first generation of CAR-T cells. Those CAR-T cells didn't have a co-stimulatory domain, right? So that's why their expansion and their killing activity wasn't sustained, wasn't the greatest, right? And then this is the second generation. That's products like Abecma, Carvykti, Lysocell, Axi-cells, those belong to this category. And then newer categories that are in research, right? They have like 2 extra co-stimulatory domains, or they have the ability of like carry, for example, certain cytokines, like for example here IL-12, or 5th generation CARs that can protect themselves from the microenvironment and so forth. Just because you probably are going to encounter these things, just for you to know. But right now, we're just focusing on 2nd generation CARs. And this is how it happens, right? You have a T cell, it's already genetically modified. Like we use a viral vector, so a virus that infects the cell, and that's how we, like end up like genetically modifying the cell to express the chimeric antigen receptor. And then this chimeric antigen receptor, as we mentioned, recognize the antigen in the cancer cell and then produces the tumor cell apoptosis, meaning the death of the cell. And there are multiple targets, right? We hear this morning about BCMA, that's the premier target, right? We have CAR T cell, we have bispecific antibodies, we have antibody drug conjugates. We have many drugs targeting this. Now we have GPRC5D, bispecifics that are commercially available, and we have CAR T cell therapies targeting also this GPRC5D antigen, which is in clinical trials right now, right? And we have also CAR Ts that target both at the same time, right? Like Dr. Hansen is a principal investigator for that study here at Moffitt, and that CAR T targets at the same time BCMA and GPRC5D. So there are other targets, like other things that you may know, like CD38, that's the target of Darzalex or isatuximab. CD138 is another target that could be used on myeloma. This is in research still. And then this SLAM7, which is the elotuzumab, or also known as CS1. So those are targets that may be coming in the future as well. So this is how the patient journey goes, right? So first off, you are referred to an academic center or a center that provides CAR T cell therapy, right? This is the main job of your primary oncologist, right? They recognize a patient that is a potential candidate for CAR T. They're referring to the academic center. In the academic center, you are seeing, you are evaluated, you are deemed to be a candidate for CAR T. Then your cells are collected. That's what we call leukapheresis. And then this is transported to the facility, right, where they are going to genetically modify those cells. It has several steps in the facility until the CAR T cell is sent back to us, and then is delivered to the patient following like the lymphodepletion chemotherapy that we provide to the patients, right? And then after, followed by the infusion. Infusion is the same way as a stem cell transplant will be infused, right? But it's faster, right? It's like the same way you get a platelet transfusion, let's put it this way, right? It's faster, it's just usually one bag. It takes about 15 minutes to infuse the cells. And then we can see here, the main thing that I want to stress with this cartoon here is like what we call the vein-to-vein time. So, right, how much it takes from the time the cells are collected to the cells are get back to you. And why is that important? Because a shorter vein-to-vein time has shown to impact survival of patients, right? So, that's what is important. That's why we stress that patients are identified early, that they come quickly to the academic center or the authorized center, and then follow the other steps to receive the therapy. And then, you know, like when we talk about, or everything that we've been talking today, this morning, has been basically immunotherapy, right? Dr. Grajales started talking about like combination therapy for newly diagnosed patients, including an anti-CD38 monoclonal antibody like Darzalex, itazumab, medications like Revlimid, medications like carfilzomib and Velcade. Those are not the classic chemotherapy agents, right? That's immunotherapy already. And along the immunotherapy also, you have CAR T, bispecifics, you know, antibody drug conjugates, and others, right? And we have the targets that we mentioned before. So, and this is very important because we're living this era, not the past 5 years, right? We're living this era for the past decade or couple of decades already in myeloma, and it's getting better. So it is something that I think we have shown already. You know, this is the most latest advances starting in 2015. See the amount of drugs and immunotherapy that has been approved and that we have available now for our patients. Now we go to CAR T, right? The first CAR T that was approved was Abecma, right? Also known as idecactagene viclolucel. They gained approval back in March 2021. At the time, the indication for Abecma was like patients who received 4 or more prior lines of therapy and that they were exposed to an immunomodulatory agent, a proteasome inhibitor, and anti-CD38 monoclonal antibody, right? So the usual suspects, right? Revlimid, Velcade, carfilzomib, daratumumab, right? And this is data coming from that study, right? This was the pivotal study that led to the approval. It was called the KARMA trial. And the impressive thing about this trial is like the overall responses on patients who have an average of 6 lines of therapy was 73%. Nothing before this product showed this overall response, right? There was nothing available on patients who were already triple-class refractory or penta-refractory who were able to achieve this. The complete responses were only 33%, and the median progression-free survival for the entire group was 8.6 months. However, patients who were able to achieve CR or MRD negative status, the efficacy was, or the duration of response or the PFS was significantly longer, right? And that's also the case because this was a dose escalation study, right? There were different cohorts at different doses. And what we can see here is like the higher doses of 450 million cells, the overall response reached all the way to 82% as compared to 73% for the entire cohort. And also the CR rates were closer to 40%, right? At the same time, there were more MRD negative on this cell dose, which at the same time translated into a longer progression-free survival. And then we have the second product, right? We have Carvykti, also known as ciltacabtagene autoleucel. This was approved in February 2022. It has at that time, it had the same indication like Abecma, right? Patients needed to have 4 prior lines of therapy, and they needed to be exposed to an IMiD, a PI, and an anti-CD38 monoclonal antibody. Now, fast forward, like a little bit over a year ago, now both products, Abecma and Carvykti, they are approved for early lines. This product here, Carvykti, is approved for second line for patients who have received at least 1 prior line of therapy, right? And that they are exposed to a protozoan inhibitor and to an IMiD, and that they are also refractory to lenalidomide. And in the case of Abecma, it's being approved now for third line of therapy, meaning patients need to have 2 prior lines of therapy, and they were triple-class exposed. This is more data on the CARTITUDE-1 study. These also were like results that we never saw on patients who have an average 6 prior lines of therapy, right? Overall responses of almost 98%, CRs of almost 83%, and progression-free survivals that were very long that we never seen, right? Like 3 years or over, especially for those patients, and it's even longer for those patients who are wearing stringent CR MRD negativity, right? At the same time, as we have seen already this morning, there are certain side effects like cytopenias, right? The low counts, the neutropenia, the low platelets, and there are other specific CAR-T related issues, right? Like the cytokine release syndrome, like the neurotoxicity, as well as the risk for infections and so forth, and as well as secondary cancers, right? Which not necessarily is the result of being exposed to this therapy, but it's the addition of all the other therapies that patients have received in their journey, right? And we have seen things like myelodysplastic syndrome, acute leukemia, or B-cell lymphoma. Now, these 2 products, either ide-cel or Abecma and Carvykti, they have proven efficacy and safety in the real world, right? We have extensively been used these 2 products, right? Dr. Hansen leads the Myeloma Immunotherapy Consortium. We have, in conjunction with other multiple academic centers, put out this data out about patients that are being treated in the clinic, right? So clinical trials, as you know, they are very limited in a way because they have a specific criteria for patients to be eligible for those trials, right? On the data that we have shown in the real world, up to 75% of those patients, if they were like looking for a trial, they wouldn't be eligible for it. But in real life, they were, and they received the therapy without any extra toxicity that was seen on the trials, with similar efficacy. As you can see here, this is for in terms of like depths in the standard of care population, right? Mostly also similar to the trial were related to myeloma progression, and then some of them were related to non-relapse mortality after like the CAR-T, which is similar in both products. But Dr. Hansen already showed us before, the comparison that she's done with Carvykti and ide-cel, right? Showing that Carvykti potentially is more efficacious. It is more efficacious, but also comes with the price of more toxicities. So now, we mentioned before now, both CAR T-cell products are approved for early lines of therapy, right? And this is what we're going to review now. So there being a lot of effort in terms of like moving CAR T-cell for early lines, right? There are multiple trials like CARTITUDE-2, CARTITUDE-4, which is the phase 3, the pivotal trial to led to the approval of CARVYKTI for second line, CARTITUDE-5 also for newly diagnosed myeloma patients who didn't plan to receive CAR-T, CARTITUDE-6 that we are running right now comparing like a standard of care followed by CAR T-cell therapy versus standard of care followed by transplant. This is going to be potentially a practice change in the myeloma world, right? We have KarMMa-2, KarMMa-3, KarMMa-4, KarMMa-7, like using ID cell in combination with the newer generations of like the immunomodulatory drugs, right, which are called CELMoDs. And this is CARTITUDE-4, right? This is for patients who were lenalidomide refractory after 1 to 3 prior lines of therapy. This is a study design. There was the patients were randomized to either a standard of care versus cilta-cel, right? A standard of care, either the patients receive pomalidomide Velcade-dex or daratumumab pomalidomide dex. And then the patients who went into the cilta-cel arm, they must have received bridging therapy. And if they were to progress during bridging therapy, they wouldn't be allowed to go to receive CAR T-cell therapy. The standard of care patients, they just did a standard of care, and then there was a follow-up. And what we can see here is the significant, how well balanced were the populations, right? So there was the same kind of median age for both groups, the ones receiving CAR-T or the ones receiving a standard of care. High-risk cytogenetics also was well balanced in this population, similar to the patients with daratumumab refractory status as well as triple-class refractory status. Okay, and this is what we saw in terms of results and efficacy, right? Following 12 months, the PFS was not reached on the patients who receive CAR-T, right? You see this line means that like 50% of the patients, as Dr. Grajales said in the morning, no longer has disease under control, right? They are no longer in the remission. So they haven't reached this after the 12-month follow-up that was around here. But even with longer follow-up of 34 months, right, the overall response remained the same, but the PFS was not reached, meaning that they are not reaching half of the patients progressing at this time. So this is very promising, right, when you compare this to a standard of care. So clearly it's an advantage. Now, people sometimes look into this initial of the curve when there was a more of like depths here or a faster slow down, right? It was because this was during the time of bridging therapy, right? Before patients receive CAR T-cell therapy, right? Some patients, they progress on myeloma, have other complications, so that's why. But then this line sort of stabilizes, right? And is sort of like plateauing here. I think we're going to hear more news about this plateauing here in an upcoming meeting from the American Society of Cancer Oncology, which is going to be very good news, I think. So this is data in terms of like safety, right? Hematological toxicities are fairly common, right? When you see any trial, hematological toxicities are going to be the most prevalent ones, right? You are going to have your anemia, low platelets, low lymphocytes, low neutrophils, right? And that prompts you for infections, right? That's why we see here infections were significant, but they were pretty balanced in both arms, in the standard of care and in the cilta-cel arm. The things that are different, of course, is like the ones that are related to CAR-T, right? Cytokine release syndrome, we don't see that with the standard of care, right? So that was seen in patients of any grade up to 76%, but the high-grade CRS represented only 1.1% of the total population, right? And then in terms of neurotoxicity, of course, we saw 20% of cases of neurotoxicity, but high-grade neurotoxicity was seen in less than 3% of the patients. ICANS was seen in 4% of the patients. That's a specific type of neurotoxicity. That's immune cell effector, cell-associated neurotoxicity. But then we have these other two things, right? The cranial nerve palsies, right? They were seeing in about 9%. In the real world, we're seeing around 10%, right? This could be very cumbersome, right? Does require treatment. It could be very distressing for patients, right? Doesn't necessarily completely resolve, but I would say like about 60-70% of patients may completely resolve this. Some series has shown also less of the resolution. And then we have these MNTs, right? The movement and neurocognitive disorders, right? There was one case, this is what we call the Parkinsonism, right? One case compared to the initial study, which shows about 5 to 6% chances, right? This also could be very distressing for patients. Doesn't necessarily will be reversible, right? So that's something that we're very worried about and that we are trying to implement some mitigation strategies to see whether or not we are able to eradicate this possibility. This is the KarMMa-3 study. This is a study that led to the approval of Abecma in the third line. Right? It was also an international open label study, so patients were randomized to either the CAR T-cell arm or the standard of care arm, and there were multiple options. In this study, bridging therapy was optional, right? And then patients also have the ability to cross over. So if you were randomizing the standard of care and then you progress, you will be able to cross over to the CAR T arm so that you can receive that therapy. In terms of efficacy, of course, also here there was a big difference in terms of like overall responses, 71% for Abecma versus 42% for a standard of care. And the same was like true for MRD status, right? 22% for ID cell versus only 1% for a standard of care. And in terms of like median duration of response, 16 months for ID cell versus 9 months for a standard of care. And the PFS was also significantly better, 13 months versus 3.9 months for a standard of care. And this is kind of a summary of like, if you look at the data coming from all these other studies, that is basically a standard of care, right? If you look at CARTITUDE-4, you look at also at KarMMa-3. This is specifically looking at CARTITUDE-4, right? Like CAR T-cell therapy prevails over all of these trials, right? There are some numbers that may look a little bit better, for example, here in IKEMA, right? But these patients were like daratumumab naive, right? Or CD38 antibody targeted therapy naive. So it's not the right population to compare. But we can see the advantage of CAR T-cell therapy when compared to other studies. And then this is something that also you are going to hear a lot about. It's like secondary hematological cancers post-CAR T-cell therapy, right? So on the KarMMa-3 study, we saw about 2% of like secondary hematological cancers, in this case NDS and AML versus none on the standard of care arm. And in the CARTITUDE-4 study, we saw 3% of those secondary hematological cancers and none on the standard of care arm, right? So there has been also the potential of CAR T itself, producing cancer, right? Because of like acquisition of certain mutations on those T cells that are genetically modified, right? The FDA have done a retrospective review, 33 cases of T-cell lymphoma among about 30,000 cases of patients receiving CAR T-cell, right? So this is fairly low. But most of those patients were CAR T-cell therapies receiving therapy for lymphoma, right? And then we have only one report of like T-cell lymphoma that developed after cilta-cell infusion, but the clone was present, meaning the alteration on the genes of those T-cells were present before the CAR T was even given. Then in terms of quality of life, right, this also has been analyzed. This is data coming from CARTITUDE-4 as well. And the quality of life is significantly better for patients receiving CAR T-cell compared to a standard of care, right? There are many things that are favorable for CAR T-cell in the sense that this is a one-time and done therapy. After that, you only go into surveillance, right? There is no need to go to the clinic every week, every other week to get an infusion, to keep taking pills every day at home for treatment, right? the element of fatigue that persists when people is ongoing on therapy does not sink, right? So CAR T cell demonstrate a meaningful improvement on quality of life. That's kind of the summary. And then in terms of cost, right? So it may sound like CAR T costs a lot. Yes, it's very expensive, but myeloma therapy in general is not cheap, right? So this is very expensive therapy. So, but if we give an outlook, if you can get like 3 years out from this investment without requiring any other therapies, right? Instead of continue other therapies, let's say, for example, standard of care, like multi-combination therapy, or either, like bispecifics that continue to go, like, either weekly or bi-weekly or every other week, like the number, the dollars continue to increase. So now the question is like, why to do CAR T cell earlier, right? And there are many, many, many answers. There are people in favor. There is people against doing CAR T too early, right? But the one thing that is very important is like the thickness of our cells, right? It's like us, like humans, right? As we age, our thickness is not the same, right? Similar with our T cells, with our immune system in general, right? As long as we continue to have more exposures to therapy, the thickness of these T cells of your immune system is going to decrease. The senescence markers on your cells is going to continue to increase. So making these cells more exhausted, right? So we need kind of like a more healthy, more thick T cells to sort of manufacture effective CAR T cells for therapy. So that's one argument in favor of doing that, right? So now, why to use CAR T early, right? The early use of CAR T cell makes sense, right? Because right now also, we're using the most effective drugs up front, right? It's not like we are using like a dual combination. No, we're using quadruplex, right? We are using an anti-CD38 monoclonal antibody. We are using an IMiD like Revlimid, or a PI like Valke or carfilzomib. So once patients progress into that, right, or if the patient was refractory to that, the chances that these patients will, like respond to another combination therapy is lower, right? So that's where CAR T cell makes sense, right? Now, the early development of this therapy led to higher remissions. We saw that, and then reduces the burdens of being in chronic therapy, right? So it's a one-time and done therapy. And then at the first relapse, as we just mentioned, many patients will be already exposed to anti-CD38 monoclonal antibody, and we will be resistant to Revlimid, for example. And then we will preserve the thickness of your T cells, and there will be more options also for an effective bridging therapy, right? We always been talking about like coming to CAR T with the least amount of disease is potentially beneficial in terms of decreasing the chances for certain toxicities, right, like CRS. Also, potentially making this thing a little bit more efficacious, right? And there is a value of extended treatment-free period, right? Nobody wants to be on therapy all the time, right? People want to get one therapy that gives them time off. You can move with your life, do other things that you have planned. You want to travel, you have family, you want to plan vacations. There are other things that you want to do. So this gives you that chance. Now, who should get CAR T cell therapy, right? Like here at Moffitt, we do a lot of CAR T, right? We're probably one of the places who do more CAR T for myeloma in the nation. But probably it's not right for everybody, right? Everybody has their own agenda. Everybody has things that they need to do. Not everybody may have a caregiver immediately available, right? But the ones patients that I will prioritize are those with refractoriness to the induction therapy, right? If you are refractory to a quadruplex therapy when you get diagnosed, then we're having problems, right? We need to move into a more effective therapy. This is where CAR T goes. People who are already triple class exposed or refractory to triple class, then they also are good candidates for CAR T. They shouldn't delay, in my opinion. Those patients who are progressing when they are receiving maintenance therapy on Darzalex and lenalidomide, right? And then those who are functional risk, right? Those who are to progress less than 18 months since the time of diagnosis, right? Meaning that these people get diagnosed, They get induction, they get transplant, they get maintenance, and they relapse in less than 18 months. Those are what we call functional high risk. Those patients, I think, also should consider CAR T-cell therapy very strongly. And those patients with high-risk cytogenetics, with high revised international staging system, or with extramedullary disease, or any patients with an aggressive relapse that accounts for extramedullary disease, circulating plasma cells, and such. So those patients should be the ones that need to be considering CAR T-cell more seriously. But as a principle, anyone, who has more than one line of therapy could be considered a candidate. And I think the main thing here is go to the center, go to the academic center to have a discussion with the doctor and then decide and plan what is better for you. So it's something about the future of the development of CAR T-cell therapy, right? We want to be able to modulate how much of these antigens in the myeloma cells are expressed, because that will impact how efficacious CAR T could be. We want to identify other targets, right? We want to engage other targets in case the targets that we are targeting at this time are not sufficient, or the patients are progressing after those therapies. We want to potentially use combinations therapy, not just CAR T alone, but for example, use this with other immunomodulatory drugs. We want to use dual binding CARs, like the trials that we have. We want to decrease also the immunogenicity of those CARs, right? So that we can keep the CAR T cells in your system for a longer period of time. And then we also want to decrease this vein-to-vein time, right? We want to be able to manufacture your CAR T cells faster, that you don't have to wait for about 4 to 6 weeks to get the cells back, right? And there are many platforms right now that are using these rapid manufacturing protocols, right? Actually, we are going to have a clinical trial with a product that uses one of these fast manufacturing protocols that cells could be delivered in less than 2 weeks. And then we're moving CAR T-cell in early lines, right? We already have second line, but we're trying to go to first line. We're running trials like CAR-T26 that are going to change potentially how we treat myeloma now in the future. And with that, I just want to tell you that most of the myeloma experts that some of you see believe in CAR T-cell. We believe it's safe. Yes, there are some side effects. Yes, we're still learning how to manage some of those side effects or how to prevent those, but CAR T-cell is an excellent option. And then, fortunately, the treatment landscape is changing, and it's changing rapidly for myeloma. And this is good because we're going to have more therapies. We're going to have different strategies to continue to treat you, right? You have to be part of it. You need to encourage your doctors to adopt new therapies, to talk to the other doctors who only dedicate their life to treat myeloma, to understand better how to serve you. We want to continue to improve survival outcomes, right? And this is all related to using newer therapies frontline, right? Like we have already demonstrated that using 4 drugs, of the newer drugs available, upfront improves your survival, improves the time you are going to be in remission. We can do the same by using other immunotherapy like CAR T-cell therapy. Side effects and toxicity, as I mentioned, are real, but we have come a long way in terms of managing and potentially preventing them. I would say CAR T-cell is safe. In the right hands, this is very safe. And then we're waiting for new modalities that are coming and that will help us overcome any of the current limitations of CAR T, not only to improve outcomes, but also to improve safety and shortening the time that we need to deliver this therapy for you. This is all I have for you guys. Thank you.